Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. Got our regular crew with us. We've got Ray Pace here to my right, and we got Dr. Hill over there. He's on this side of the table. This episode, and returning with us once again is Dr. Jordan Singer. Third, I think this is your third time around? Second or third time around?
Yeah, third time.
So, hey, always appreciate you coming. They know it'll be a great follow-on to what we talked about in a recorded session earlier, which is psychiatric emergencies. Also part of our CE for this month, right? So they're just kind of a whole psychiatric smorgasbord all this month. So we're on the road again. This is, of course, not our usual studio. We're in beautiful Richfield, Ohio, and we would, of course, like to give Assistant Chief Mike Lester a moment to tell you a little bit about his department and his staff, and say hi here from Richfield.
First of all, welcome to Richfield.
Thank you.
Richfield consists of the village and the township, approximately 25 square miles. We have four full-time staff on per shift. We try to go up to 5 using our part-time. We are a combination department. Run between 1,500 and 1,600 calls a year, which doesn't seem like a lot, but we are right in the middle of Cleveland and Akron, and our response times are very lengthy.
Yeah.
I'm sorry, our times to the hospital are very lengthy. We do service a lot of highway. We have 77, 271, and we do the turnpike. We're contracted to them well outside of Richfield. Just has to go by exits. We're probably total 30 members. But again, welcome to Richfield.
Thank you for having us. Thank you. Yeah. So, as always, we'd like to give a shout out to our sponsors. Everything we're doing today, all this video streaming, all this audio streaming, it's all going out over the FirstNet network, the First Responders cellular network. They were courteous enough to give us the bandwidth to do this. So everything right now is completely wireless and hanging on their backbone, and we appreciate them. If you're interested in doing anything with FirstNet as a first responder or any type of healthcare provider, if you go to prehospitalparadigm.com/FirstNet, there is a special offer that they were gracious enough to afford us to give to you. So if you want to check in on that, that's available to you. And all of that data wouldn't get out into the atmosphere without a router and Cradlepoint. They're the makers of hardware to get all that information out on the network. That's robust stuff made for mobile use. All that's going out over over Cradlepoint hardware, and again, we want to thank Cradlepoint for supporting the podcast and giving us the hardware to do it. And if you are interested in hosting us live at your station, again, prehospitalparadigm.com, click on podcast, and there is a link to a form to host a podcast. We're just going to ask you some basic stuff. We'll get in touch with you. Beginning next month, we'll be in Kent next month, and that's our first quarter of on-the-road live talks. And at the end of that, beginning or end of that, at some point during that show, we're going to anybody that's interested in hosting us, we'll pull that name out of a hat on that show, and we'll be coming to visit you, and we'll bring all of this gear, and we'll set all this up and do it at your department. So. If you're interested in hosting us, please hop on that. And again, prehospitalparadigm.com. That is our catch-all website for all of this information, all of our previous work, all of our free open access medical education, whether it is Pharmacy Fridays, whether it's the Medical Director Minutes. Dr. Singer and Dr. Spanner both do an excellent great cases section where they review cases that are just great cases, just like the name implies. So whether it's a learning case or whether it's absolutely stellar care, hop on prehospitalparadigm.com and check out those various links. And the biggest thing you can do for us is to help us move this along and get this education out into the world is subscribe on YouTube. That's our big push for the next couple of months, is to build that. We've got plenty of people following on Facebook, but our YouTube's a little soft. So we're asking you, if you haven't already, pop in and subscribe on YouTube. So that'd be great. So, all right, we got all the minutia out of the way, and guys, right off the rip, we did a little bit of CE with them on psychiatric emergencies, specifically pink slips. Any questions that you guys had that you want to start off with? Anybody want to be the first one to say anything? So, go ahead.
Well, not on this. Hello. This question is from the introduction.
Yeah.
Do you have to be under UH Med Control to put your department in the raffle to host you guys?
I would say yeah. I don't think we've ever actually crossed that. We haven't crossed that bridge, but yeah. Let's at this point let's keep it right to our med control departments. But so, well, anyway. Dr. Singer, welcome back. A lot of the stuff that we spend time in the psychiatric world talking about is whether or not the patient has capacity, and I feel like we continue. We've been harping a lot on that lately, but I had a very kind of irritating conversation with a colleague a couple of weeks ago, and one of the things that we talked about on your recorded session was using med control to back up your belief whether the patient does or does not have capacity, whether they would need to be pink slipped or whether you can take them involuntarily. And the frustrating part of that conversation was they were just like, no, I'm just going to call med control, let them tell me what to do. And of course, I had a bit of a retort of, no, you should have formed your own opinion, and then what you're now doing is they're backing up. We've got multiple people having an opinion about that patient contact. As a matter of fact, I think in that last episode, didn't you step out? You had to take a call exactly for I think it was a capacity problem. But you want to speak towards that?
Yeah. So, I mean, it's something we take for granted, our ability to make a decision.
Yeah.
I mean, anyone in this room, we're talking to them, it's not like we have to do a capacity assessment. If we make a decision to do something, everyone's going to say that makes sense, that's their
let's do it,
decision.
right.
But when we're dealing with someone who's confused or something isn't quite making sense or they're making a decision that doesn't quite pan out or make sense with something you do, we have to formally decide, do they have the ability to make that decision? For the same reason that someone who is incredibly intoxicated with alcohol, and we don't let them make their own decisions if they can't show that they have the ability to do so. And so we have to do that assessment every time. And yes, med control is there to help, because some of these, when they clearly lack capacity, you don't need med control. You can just bring them to the hospital against their will. And when they clearly have capacity, you don't need med control. You should let them make their own decision. But for the gray areas in the middle where it's a little bit confusing, that is when involving med control is very helpful, because you have your opinion on whether they do or do not have capacity, and you have med control. And so if both of you agree that they lack capacity, it kind of defends your guys' decision to bring them there against their will. Because if they have capacity and you take them, then you've kidnapped them. And so we don't want to do that. We really want to make sure that we're doing right by the patient,
right,
but that we're also balancing the risk of kind of kidnapping with that we don't want to abandon them and leave them there when they lack capacity. So it can be difficult. Don't make med control your crutch so that you can't make your own decision or assessment, but utilize med control. We're here to help you in these situations when it's gray.
Right.
Or sometimes you're having maybe EMS thinks one thing, police is on scene, they
Perfect
think another.
example, yeah.
Med control is the perfect tiebreaker between them two.
Yeah, the buffer.
To say, police think this because of this reason, I think this because of this reason. Doc, what do you think?
Yeah.
I think like when you call medical control, it's almost like we're presenting our case to you.
Yes.
Like, hey, Dr. Singer, this is Ray, I have this case, and then I present and say, this is why I think that, and what do you think? Or I think this is gray, and we need your assistance in it. I don't think any I don't believe any EMS agency should just solely rely on, I'm just going to punt this to medical control. I don't believe that's fair to the physician.
Like I said, that was a very frustrating conversation.
Oh, sure.
You want to frame things for us,
Absolutely.
and make, because the goal is for us to do what's right by the patient.
Yeah.
We may not agree with that. Like if the patient wants to refuse and they have capacity, I don't have to agree with the patient, but the right thing to do is to let them refuse if they have capacity.
Everyone has the opportunity or right to make the bad decision, right? I can make the bad decision to go out and get drunk and go drive a car. That's a bad decision. I have the right, as an American, as a human being, to make that bad decision. I may not agree with it, but if that patient can explain to me why they're making that bad decision, then they have capacity.
Right.
And I think that gets really muddy, and you bring up the drunk driving thing, right? Is how often are we called for a situation where this patient's intoxicated, they have to go with you, right? And just the presence of alcohol alone does not necessarily strip capacity.
You can be above the legal limit to drive
Yeah, that's
and
a
have
trick, right?
capacity. I mean, we've all met somebody who drinks alcohol every day, and they may be sober, clinically sober, that you couldn't tell that they had any alcohol on board and have blood alcohol levels in excess of the legal limit by a lot, because they have capacity. They probably physically could drive, but they legally can't because we have blood alcohol restrictions. And so, in the end of the day, if they are clinically intoxicated, i.e., you're talking to them and they lack capacity because they have so much alcohol on board, they can't refuse. But if they have alcohol on board and they can demonstrate capacity based on our protocol, then they absolutely can refuse. They may not be allowed to drive. And you can tell them,
Correct.
hey, if you don't go to the hospital, we strongly recommend you don't drive because that officer is
guy's
going to
gonna-
arrest
right,
you.
right.
But that doesn't mean that we can force them to go against their will to the hospital if they have capacity.
Yeah, those situations get tricky sometimes.
I think when they get gray, to Dr. Hill's point, Dr. Singer's point, that's what medical control is there for.
Yeah.
EMS presents it one way, and the police maybe have a different mindset or a different understanding of it, and medical control can essentially be the tiebreaker, as you put it. I think that's good, but we talked a little bit about that before we started too. Yeah.
And we're always going to err on the side of caution because we're not there. And that's the other thing is when you're calling med control, you're calling us for our opinion. We're not there. You need to paint a great picture for us, but ultimately we're not there. You need to have your own opinion formed before you call us. You might be on the fence. You might say, I'm leaning one way or the other. But again, we're not there. You got to paint a great picture for us. And if we're unsure of what you're telling us, the default answer is just transport them here. I will evaluate them myself and figure out what's going on.
And the other benefit of calling med control, at least in our system, is the line is recorded, and so there's a lot of benefit whenever I'm in this situation. Is I tell the patient, I tell the crew, put the patient on the phone.
Absolutely.
Because if I have a full conversation verbally on a recorded line that demonstrates that they have capacity, that is very helpful to kind of back up my claim that we're going to let them stay, even though we disagree with it. Or if they can't demonstrate capacity, it kind of shows why we, both med control and the providers on scene, elected to potentially sedate this person against their will to bring them to the hospital because they could not demonstrate capacity. And so it's kind of useful evidence on the back end if somebody later disagrees with what we did.
Yeah, or there was some sort of follow-on incident.
Correct.
Yeah, absolutely.
Yeah.
I guess that really kind of goes into a little bit of discussion about how to document these things, right? Especially that conversation with medical control. That, hey, doc was on the phone. This was not just a singular choice by EMS.
And then you could also utilize family and friends on scene, both to kind of help you or to kind of explain to them why you're letting them stay. Because oftentimes family or friends are the ones who are calling 911 and the patient's refusing. And you can kind of say, hey, I understand why you called 911. I agree your loved one needs to go to the hospital. Unfortunately, your loved one is demonstrating capacity. So unless you can convince them to go, I can't take them. But if they change their mind or something changes, give us a call back and we'll reevaluate.
All right, but I'm their medical power of attorney. I say they need to go.
Yeah, so that can be very frustrating. And so the key to know with medical power of attorney is their power doesn't kick in unless the patient lacks capacity. And you should tell them that. You should say like, hey, I realized, and how we talk to these people is important. That's why I'm kind of giving examples, because the language we use, you want to show that you understand, that you empathize with them, that you're respecting them, but at the same time, you can't violate the patient's rights.
Correct.
So say like, hey, I understand you're advocating for your loved one. I realize your power of attorney, but your power doesn't really fully kick in to make decisions until the patient lacks capacity. At this point, the patient has capacity, so all you can do is advocate for them, which you're doing, but we can't make decisions for your loved one because they have the power to do so themselves. So if you explain that, you're kind of respectfully kind of helping them understand where their power lies and what they can't actually do in this situation.
but I'm in their will. That's important, right?
Yeah, well, not in this moment in time.
Right.
And capacity can change, right? They could have capacity right now, and 30 minutes later, something can change and they could lack capacity. So every moment, you technically are reevaluating capacity in real time. And for instance, what if somebody's hypotensive and peri-arrest? When they're alive, they might have capacity, and then all of a sudden their blood pressure drops and they're unconscious. Well, now they lack capacity, and so now you do what's right in that situation.
Same with blood sugar, diabetic emergency,
Yeah,
right?
perfect example.
Their glucose is 20, we fix them, and now they are alert and oriented times 4, and they're refusing care. Happens all the time.
Yeah.
Yeah. But the
We had some questions.
yeah. Ooh, Caleb.
Yeah, I have a question. So we work pretty well with our PD, and we have a great relationship, so we don't ever really get caught in this scenario. But say our PD does pink slip somebody,
Yeah.
and then we do find them they have competency. How do we go about that
Are
situation?
you saying capacity or competency? Okay.
Capacity, excuse me. How do we go for that scenario where they have the capacity and that they can make their own decisions, but our PD is still pink slipping them?
So you bring up a good point. So pink slips actually only really apply to patients that have capacity. So the reason is if somebody has a psychiatric emergency and they lack capacity, somebody who's grossly psychotic, clearly can't make their own decisions, is a danger to self and others, you don't need a pink slip to take them to the hospital. They have no capacity. You do what's in their best interest or what their POA is requesting. But the reason we have pink slips is for the, let's say, the patient with suicidal ideation who has capacity, who totally understands that if they don't go to the hospital, they will kill themselves. Like, I have a plan, I will get a gun, I will shoot myself, I intend to do this. And you ask them, well, what would happen if we don't transport you to assess for capacity? Like, I'll die. They're right, they have capacity.
Right.
The whole point of pink slips is to allow us to transport someone with an acute psychiatric emergency, putting them at imminent risk of self or others against their will when they have capacity. So in this case, I think the question you're maybe getting at is, what if you have somebody who police pink slips who you don't think needs to be pink slipped? Like, let's say they...
It's not a psychiatric,
Part-
say it's an intoxication like you were speaking earlier.
Yeah.
And somehow police pink slip them for not being able to, or just not wanting to go and they wanted to.
So pink slipping a drunk person, basically.
Which
So
happens sometimes.
unfortunately, that would be an illegal use of pink slip based on my, at least, understanding of reading the Ohio Revised Code on that. And so in this situation, the goal is to try to help the police officer make the right decision in this case. Because if he's pink slipped them, that person's going to go to the hospital. But what I would say is, like, sir, I hear that you're pink slipping this patient. Help me understand why you're pink slipping this patient. My understanding of pink slip is that this is for somebody with a psychiatric emergency, putting them at imminent risk to self or others. This patient seems more intoxicated and doesn't have a psychiatric emergency, so I'm not understanding what's going on. Help me understand, because if the officer can explain it to you, then sure, maybe the officer was right and you didn't understand. But if they can't explain it to you, that may help the officer figure out that maybe I shouldn't have pink slipped this person, and hopefully that gets them to make the right decision. And then if they do want to pink slip them and you don't think it's appropriate, the key is that pink slipping a patient who's not agitated is a law enforcement issue, not a medical issue. And you could just inform the officer, sir, if you'd like to take them to the hospital for an immediate psychiatric assessment, you're free to do so in your vehicle. But they're not having a medical emergency, so we don't see the need to transport. And that's kind of a respectful way of guiding them to at least either take them themselves or not do the pink slip. It's a good question, though.
So our good friend online also asked that
Ask the same question. Yeah, almost the same time. So
Shout out to Chris.
Chris, yeah, thanks for putting that up, but dude beat you by 15 seconds in the room.
So I want to add on to that if we have time that you want to have that conversation on the side of the road in the patient's house, that's great to do that and have that conversation. Sometimes it's just easier when my squads and I, no matter what, Jordan has this with his squads, I have it with my squads. It happens more times than we want it to. It's just easier that once they present that pink slip to you, transport the patient, give report to us, and just have us handle it on the back end. Because we'll go back and we'll educate them, right? It's just, sometimes it's not worth having that fight. You have a pink slip, you have a legal piece of paper that allows you to transport that patient, and maybe just have that conversation with the patient, be like, yeah, that cop's being a real pain in the butt. I don't think that you need this. Come with me. We'll talk to them at the hospital. We'll get you through this. And that might just be your easy exit out. Transfer them here. Talk to us. We'll likely, if that's the case, if we just think they're intoxicated, we'll destroy the pink slip, rip it up, and then we'll just discharge the patient.
Because the pink slip only at least a pre-hospital pink slip only forces the patient to go to a hospital and be evaluated by a physician within 24 hours. We're not going to sit on them for 24 hours. We're going to see them right away. And so we can immediately decide, we agree this person needs more formal psychiatric assessment, or as Dr. Hill said, we disagree with that this person needs psychiatric assessment. We evaluated them, and now we're discharging them, which is something we're allowed to do.
Because if you get in the weeds about pink slips, at the very bottom on either the first page or the second page, there's an attestation that's a medical professional. It reads as the medical director, or was it say there technically?
Chief clinical officer.
Chief clinical officer of the hospital has to attach an attestation that we agree with the information that was presented to us in the pre-hospital pink slip. So if we disagree with that, it goes away and we discharge the patient.
Some things to be aware of, especially maybe if not law enforcement pink slips, but some other psychiatric person who has the authority in the state to pink slip, is sometimes they may have information that the patient hasn't told you, or some kind of collateral from friends or family, because these patients often are not 100% truthful because they don't want to go to the hospital.
Correct.
So they may tell you what you want to hear. Sometimes if you can't get to the bottom of it, they may just need to come in so that we can kind of get that collateral and make sure that the whole story that you guys got is the correct one and that they can be discharged safely.
As was discussed earlier, based on our geographic size, if we're relying on the medical director for a pink slip, are we committed to transport to that hospital? So mechanically, how's that going to work? We get our med controls UH and we end up transporting to some other facility. How's that pink slip transmitted to where we're going?
So the pink slip has to be a form that is handed to the hospital. So typically, at least what I've advised my crews, is if you're going to go to a specific hospital, if that's your intent, I would call them for the pink slip if they need a pink slip.
Medical call.
So if you do call, let's say you transport to Akron, and Akron is not willing to pink slip, I would call your medical director and see if they're willing to pink slip. At least if you call me in the middle of the night and I have to get up out of my bed and go to the hospital, present a pink slip, and that's in the best interest of the patient, I'm going to do it. I'm not going to be the happiest camper about it, but I'm absolutely going to do it because that's my responsibility, both to that patient, to support you guys, and as the medical director. But the best thing would be to call the receiving facility for a pink slip if you don't already have one but think it's necessary.
Okay.
I think in typical fashion here in Richfield, we're not an exemption that you guys get a call right in the middle of this, so.
Absolutely.
We were joking about a call counter.
I added it.
Oh, you added it?
Yep.
The first one popped up there?
Sure did.
It's happened
And that,
everywhere. It's happened everywhere.
It's going to happen every single time. It's, the EMS
So
guys
if you have
will
low
speak.
call volumes, have us live on your show.
Yeah, right. Yeah, if you're yeah. Yeah, if you need to justify it to counsel, or we got you. We'll come set up. And that question kind of dovetailed in with what Joe asked online there, with doctor's not on scene, but verbally states he'll sign it, and that was a great explanation.
Because that's the thing, is it's just good to know who can do a pink slip. Unfortunately, the way the law was written is EMS and fire was left out of who can write a pink slip, and that's just unfortunately how the law was written. But law enforcement and physicians can, and certain other kind of people with psychiatric training that are specifically listed in the ORC. So if police won't help you, please utilize ER physicians or your medical director, because that's what we'll do.
Do we want to, Chris's other question, do we want to bring that up?
So can you discuss exactly how the pink slip needs to be filled out and signed? We get a lot given to us that are filled out and have been told they aren't legal unless they are filled out and signed, but we don't always have time to sit on scene.
That's 2 restrain monitors and a front home. This is going to be a 3814 Faith Lane, 3814 Faith Lane, 89-year-old male. He's having some difficulty breathing. He is on an oxygen tank and does seem to be working just fine. The request to use the front door entrance. Timeout will be 1930.
So that's a good question. I actually don't know the answer to that myself. I think that as long as you have if somebody who can legally write a pink slip does their best to write one, that is sufficient, and that you are probably, my understanding would be following the law because you're doing what makes sense with the way that the law was written.
Right.
I think it almost positively needs to have an explanation of why they think the person is both having a psychiatric emergency and that psychiatric emergency puts them at imminent risk to self or others.
Correct.
Both those things are important, and it needs to be signed by a person who could legally write it. And my understanding is as long as you check those three things, that a pink slip is legal and that you're allowed to follow in that situation.
Fantastic. All right, what else do we have? Hey, Caleb, you're slacking, buddy. You got one job, man.
So you had made the comment about, if you got called in the middle of the night, that you would go and deliver the pink slip to the hospital receiving the patient. What do we do when we get a phone call and says, oh, the psychiatrist is on the phone, we talk to them on the phone, they say take them in? Are they physically going to that hospital to meet that patient and turn in that paperwork? Or, how do we know that that's also valid too?
I think you would need to have at least just close the loop with that and say, hey, who is this person who's making this pink slip or writing it? And two, what is their plan to present that pink slip to the hospital? Because that kind of needs to happen. And making sure that at least that you have closed the loop that they're going to do that. Because that's the thing is, one of the things to remember is that we're not allowed as EMS to take custody of patients. That's not something we have the power to do. We're allowed to provide medical care to patients. And so if they're agitated and violent or combative and they need sedation, that's a medical emergency and we're allowed to render that care. But if the patient is kind of compliant and saying, you are not allowed to touch me, do not take me to the hospital, and they have capacity and all they have that you have to work with is a pink slip, that's really more of a law enforcement issue. So you need law enforcement on scene to take custody of that patient. Now if they get violent and agitated in the process of that, then they may need you guys to step in, because the safest thing for that patient is to sedate them, because agitation itself can be very dangerous not only for you and law enforcement but predominantly for the patient, because it's that agitation, that revving up of their sympathetic surge and all the downstream effects of that can be dangerous. So that's really when we have to step in. But I mean, most of this is a law enforcement issue, just often we're getting involved to help them, and because oftentimes that can be better for the patient.
So I think it's easier just to say that in order for that patient to move, you need a written statement for them to go.
That's also true.
The only caveat to that is if your medical director that you're on the phone with is going to meet you there to write it, that would be no different than police following behind in the ambulance and then write the pink slip on arrival. Not to get too on the nose, but if we look at, and this is only Ohio for our friends that are not in Ohio, but
are you finding a reason to read ORC?
Yes, I am.
This is how I get to sleep at night.
I don't like to, but when I ask questions to people, they recite it back to me.
Right,
so.
yeah, exactly.
So Ohio Revised Code, section 5122.10, B. A written statement shall be given to the hospital by the individual authorized under the section to transport the person. The statement shall specify the circumstances under which the person was taken into custody and reasons for the belief that the person has a mental illness. So that piece of paper in writing needs to be at the hospital when that patient arrives, or around the time that patient arrives.
As long as you're trying to close the loop and kind of collaborate with the person writing and be like, hey, this is just how the law is written, so you got to help us make this happen so that we can transport this person, then I think you've done your due diligence as an EMS responder.
I had this situation in residency where we had a call from a psychiatrist that wanted to pink slip a patient that was not with the patient at all, and they wanted a pink slip. I'm like, well, I need a pink slip. Well, you can't just take my word? No, I need a piece of paper, documented, signed by you, states what your beliefs are. So I guess I go to a little more strict interpretation of ORC, and we've had this question even off air about
correct, yeah.
Where do we draw the line on what do these words mean in ORC, and how strict do you go in and interpret them? I go a little bit more strict, that I want that pink slip to go with the patient, because that way there's no questions asked, right?
It's bulletproof.
I also get away from the, oh, police say they're going to bring it by later. No, they're not going to bring it by later. You're going to either transport with the patient, so they're in your custody, or you're going to provide a signed appropriate piece of paper, pink slip, to the transporting agency. That's no different than what we have to do when we send a patient. If we're sending a patient to a psychiatric facility, we do the same thing. We fill out a pink slip that goes and has to travel with the patient to their final destination. So when we're admitting a patient to a psychiatric facility, after we've done our medical clearance, after the psychic team is evaluated in concert with the ER docs, the ER docs are the one filling out that pink slip and signing it, saying that this is our belief as to why we're going to suspend this patient's rights for 72 court hours before, so that way they can go to that psych facility, be evaluated, and then they can either say, yes, this patient's going to sign in voluntarily and agree to stay with us, or if they're not agreeing to that, then they have to go probate them and go in front of a judge and convince a judge that we're going to then get a court order to keep them in that facility. That's how the big process works. It maybe gets lost on the front end with EMS and police, but that's how the whole process works. Even I have to justify why I'm essentially kidnapping this patient and sending them to someplace that they don't want to go.
So I'll ask a question for one of the squad crew members that was brought up earlier, but they're not here. If you have a patient, and make sure I get this right, that law enforcement has handcuffed, and now they're in the ambulance, and they said, you know what, we're going to ride behind you, we're right here, don't worry about it. Is it a requirement that that officer has to ride as an attendant in the back of the ambulance?
Yes. Hard yes.
Unless you think you can get those handcuffs off safely without a police officer, which you cannot do, they need to be there with you. Alternatively, you can, if you don't think they need the handcuffs, you can ask the officer, if you don't want to ride with me, I feel safe right now, I would prefer that you take off the handcuffs, just because we realize how restrictive it is to adequately assess perfusion of the hands when they're behind them, and that kind of inhibits the patient's ability to kind of sit in a comfortable position. They may not be able to breathe as well. I mean, depending on how tight they are, what their shoulder mobility is, it may kind of restrict their lungs' ability to expand. And so that is definitely something we don't want to really do.
And could we transition, Doc, to your point, if we had that patient that was on our cot that's handcuffed, could we safely transition that patient to some sort of soft restraints in our world, from the police world to our world, and then we could safely transport the patient in a comfortable, appropriate position that follows our protocol, and then if that patient needs some type of sedation, we could also follow it up with that to remove the handcuffs and switch to a safer alternative for transport.
And that might be a nice way to de-escalate the situation too, to work with the patient and be like, hey, let me see if we can get this handcuffs off you.
See if we can get them off.
Yes.
Yep.
Go talk to police, say, can we get these off them? We'll transport them. We'll get them calm. We've calmed them down. We're good to go.
Yeah, because that's what we usually talk about, in our organization, is how do we transition to that? It's better for transport, it's better all the way around, and then you're not in that type of predicament, for a lack of a better word.
And if they're adamant that the patient stay in handcuffs, a police officer must ride in the
Right,
back.
yep.
They're coming with you.
So I had this on the turnpike with the State Highway Patrol. They wanted to transition them to zip cuffs.
I would say no, because I don't think,
Which is what I did.
yeah.
Because I still considered it handcuffs, and he was
Yeah.
wanted, and I said somebody needed to go, but you can safely just cut those off with
Cut
trauma
those, yeah.
shears.
I think if
You
they
cut 'em
need
with
that
trauma
kind
shears.
of, if they need that kind of hard restraints, you need a police officer in the back, just as backup of
was my
muscle.
feeling.
Ideally, we can just get some form of sedative on board, whether that be verbal de-escalation, a verbal sedative, or a chemical sedative, just to kind of keep the patient calm for their safety as well as your safety. Because what I don't want to have happen is you're in the back of the rig with someone who becomes violent, and then you get hurt too, which your safety comes before anyone else's.
Yeah, anything that's handcuffs, I mean, would you ever zip tie a patient's hand to a cot? I mean, that's essentially what you're doing with zip cuffs, right? So
I would ask I think a good way of kind of coming to an answer is asking the law enforcement officer, why do you really want them to have handcuffs or a zip tie? Is it because you're worried about them running away? And if that's the case, you need to be in the back of the rig. And if for some other reason, help me understand, because it's probably that they just want the patient to not be able to run away easily. because they want to keep them in custody, but I would just be like, I can't keep them. Like, that's not my responsibility. Like, my responsibility as an EMS provider is to provide EMS care and medical care. If you want to keep custody over this patient, you're coming with me in the back of the rig.
Right, I wasn't worried about cutting zip cuffs off someone, I was more worried about why he's in them.
Right.
Yeah, right. No, that's a good question.
And I think if under review by anybody, handcuffs are never a restraint, zip tied or otherwise.
I would agree with that statement.
If they're in any type of handcuff or zip ties, they're in custody of police, and that you guys are not law enforcement officers. You cannot take custody of a patient. You're only there to provide medical care and transport.
Even if you are a law enforcement officer with another hat on, while you are operating under EMS, you are not a law enforcement officer.
Anything else? All right, so you have that patient who is clearly lacking capacity, who is just an absolute wildcat, and we are going to have to administer some sort of sedative, tranquilizing agent. How do we make the differentiation as EMS whether to err on the side of, say, something like a benzodiazepine versus going with something with a lot more clobber, if you will, in a ketamine for tranquilization?
Yeah, basically, if I look at a patient and all I see is the Incredible Hulk in terms of how agitated and angry and strong they are, they need ketamine. Like, if I see someone who is incredibly profoundly agitated, they are of imminent risk to not only us and other people around them, but most importantly to themselves for any number of reasons. And the most effective way of controlling their agitation is with ketamine. The beauty of ketamine is it works within minutes, like 1 or 2 minutes, and it can be given IM. And our protocol just is to give a flat dose of 250, and then if that fails to work within 5 minutes, another dose of 250. The key is that once they do go down and become sedated, which they hopefully will very rapidly, we're going to use any and all monitors to watch them. If you think, should I use it, the answer is yes, 150%. And that includes capno, glucose check, cardiac monitor, getting a 12 lead, pulse ox, then work on an IV, just because if we've sedated them, they are a critically ill patient. Like, any agitated patient is by definition critically ill. We should be doing Q 5-minute vitals at the least, at the most, or sorry, not the least frequent we should do the vitals is Q 5 minutes. And the reason is because we don't know why they're agitated. They could be agitated because they struck their head really hard and have internal bleeding, or have a bleeding in the brain. They could have some other form of shock. They could have alcohol withdrawal, any number of things that is fatal. And so we want to catch anything that we can reverse in the field. Assume the worst until proven otherwise.
That was absolutely my favorite part from the recorded version, which was do all of the things. All of the monitors. And,
yes.
You know, that is a perfect take home for anybody that requires any of these agents, right?
Plus that makes sure that we're not having tunnel vision as to what is wrong with this patient. We still continue to look for another answer besides a behavioral emergency, that you mentioned earlier, whether this is low blood sugar, is it an internal, is it some type of internal bleeding within their brain.
Sure.
It still keeps us, I think, on point to make sure that we're constantly reassessing our patient. We're paying the highest level of attention to all of their vital signs, seeing if anything is changing, looking for a trend, and we continue searching for that answer instead of this is just a behavioral emergency. That's all it is. We want to continue to look. We want to continue to look and see we want to make sure we're not missing something, for lack of a better word.
And beyond that, when you upload that and merge that with your chart, you've got that. You've got that trend of data. You've got proof.
Yes.
Hey, nothing bad. No badness happened in our care after we took these steps, right?
Sure.
Yeah, that's as much for them as it is us to prove. We've done everything we possibly can. We've exhausted all of these types of protocols. We've done every single type of monitoring and test that we can to try to figure out, is there something else maybe medically wrong with this patient?
And that is definitely the case, that you merge the electronic file with your
run report.
With your run report. That's not the one that you should be pecking in your vital signs manually, right? That's your justification, really, or that you did everything appropriate.
Yeah, behavioral emergencies are in themselves, if it turns out to be behavioral, once you sedate them, is rarely going to cause any long-term effects. Like, they're not going to immediately die because they were having a psychotic break once you've sedated them. But if you assume it's psychiatric and it turns out that that they were hypoxic or hypoglycemic or some other medical thing that was masquerading as psychosis, then they could actually die in the acute setting from that. So it's better to assume medical until proven otherwise, which we can't do in the field. They often require blood work, a CT of the head, and some other workup. And so our job, because we can't rule it out, is to assume everything is medical and reverse everything we possibly can.
And all of that was my setup for this point, which was we changed the protocol for 24 to expressly address that problem, right? Because historically it was really framed up as it needed to be a behavioral emergency, right? It expressly said something to the effect of, not for medical etiology, right? And it listed a few things. Now we're changing that to exactly that situation, right? So doesn't matter whether it's an obvious case of, they're encephalopathic because of sepsis or stroke or something else. We're still going to take control of the situation, do all the things, do all the monitors, and then we can let you guys tease that out on the back end.
Because, all we have is an agitated person in front of us. We have no ability to ask them a full history and figure out what's going on. We could have clues, but we have no ability to rule it out. So we should assume that all agitation needs to be treated based on the degree of agitation, and then we'll figure it out later.
Yeah, but that undifferentiated case is what I wanted to bring up. Is, we taught so hard on that before, like, no, it's got to be behavioral, it's got to be behavioral. I think the only thing that really persists in protocol in that space is the use of the olanzapine, which is for psychosis, right? I think that's the only thing left in there, but the use of a benzodiazepine or the use of ketamine, we've opened up dramatically for 24.
The thing with olanzapine, at least in our protocol, olanzapine takes a while to work. So it's not going to start working until long after the patient is likely in the ER. So if somebody needs to be sedated, olanzapine is not going to help. But if you can have a conversation with someone like, yeah, they have some underlying psychosis and that's what's going on, and I'm worried that the hustle and bustle of the ER may rev them up and cause them to get kind of agitated and have an issue. If you can get some olanzapine on board so that when they get to the ER and everything is starting to stimulate them, that they don't get pushed over the edge and actually have a true medical emergency from their agitation.
Yeah, they're hearing things, they're seeing things, they want the help. They'll take the pill from you, right? Do you want to feel better in about 10 minutes? We do come across those patients sometimes, and that's a great...
it's fitting for where we are here, because we talked about, the transport time of Richfield. So, if it's going to be 20 to 30 minutes one way, and you're going to take that patient to the emergency room, and they are going to be, that could be a trigger or overstimulation for them once they're at that facility. It's very applicable here versus maybe an ambulance that has a 5-minute transport time.
Yeah, but they get it on board. They got a 30-minute. They got a 30-minute run. Two-thirds of that call, the drug's taking effect, right? So you get the benefit of it.
And I think my only pharmacy plug here is going to be what we talked about before: is do not confuse olanzapine with
the same thing, right?
Onidazepine. Yes. Since we've changed and went to the generic names throughout the protocol and the paperwork, please do not confuse one drug with another, and we've even tried to build a safety factor into your drug box with olanzapine being placed into a bag with a bright green or bright yellow label that says Zyprexa in the past, now that we've went to the generic name. But make sure you are taking the extra second to look at the medication before you give it to your patient. I don't want to go through the 5 R's, but I would be letting pharmacy down if I didn't talk about that. So they'll be happy.
It has happened.
It has happened.
It has in fact happened.
It has happened.
We're not grasping at straws here. So
when we're talking about which medication to use in the patients, I think a good way of thinking about it is this mild, moderate, or severe, right? You're mild. I have some insight. I'm calling you because, hey, Ray, I'm not doing so great today. I need help. I really want some medication to help with the thoughts that are going on. Olanzapine's your drug, right? Your moderate is going to be your Haldol, Benadryl, benzodiazepine combination. To I want to get an antipsychotic on board. I want to help calm this patient down, but they're not spitting at me, they're not throwing punches, they're not biting me, they're not spinning around on the ground, they're not trying to rip things off the walls. That's my moderate. And then my severe is I'm throwing punches, it's taking 6 people to hold me down on the ground. I just gave it on my last shift because I was patient came in handcuffs with police, and essentially 4 points. We got her off, and then she goes to try to bite our officer and then scratch at me. So we're not going to play that game. We're going to give you ketamine. We're going to do our workup. And because she was intoxicated, we don't know what's going on, right? I know she's intoxicated. I know she's trying to fight with police. I know she's trying to bite one of my officers and scratch at me. I need to figure out what's going on with this patient.
Did you do all the monitors?
I did all the monitors.
Okay,
yes.
that's going to be a take home for this.
He practices what he preaches.
Fantastic. Or you preach, right? Do all the things. All right, well, that actually segues nicely into that next question, Dr. Hill. If you have an adult female that is roughly 120 pounds, would 250 milligrams of ketamine still be appropriate? Is there any concerns for overdosing? It's like you set yourself up for that question, even though.
So for my patient who was not, if we're looking at the strictest, if we're looking at what an actual dose is going to be, for my patient 2 and 120, it would be more medication than would be. I got to do some math now. Hold on.
So in general, at least in the hospital, and a lot of protocols outside of our system use a weight-based protocol, where the standard dose is 4 to 5 milligrams per kilogram. Our protocol is based off of data from OSU, which is why we did these standard doses. So for a very agitated patient, you don't have to worry about doing math. At least they found that it was safer in the study that they did. Right. But yeah, other people who are listening from other systems may use weight-based protocols. So there's a chance that you could overdose a smaller patient.
You could. So 100, by my quick napkin math, 120-pound patient was...
I use 60 kilos, 240 is
54 kilos, times that by 5, it's 270. So you're technically, by the math, not even overdosing them if you're doing 5 mg per kg.
5 mg per kg, yeah.
I did 4 and got
to, yeah.
Something to always remember is, if you think the protocol doesn't apply to a specific patient in front of you, you should always call med control early. So if you're worried that the 250, or if you have to give another dose, the 500 is far more than this patient needs and would be dangerous, even though the protocol allows you to do it, you should not do it. If you have the wherewithal and the understanding that that is not what is right for that patient, you should call med control early and say just that. Like if you call me and say, hey, the protocol says this, I think it's inappropriate because of this, I think this is better, I will applaud that and say you're most likely 100% right in that situation. I'll give you the order to do it, and then that's good enough. Because you have an online order, you can do it if it's in the scope of practice.
And I think what we're trying to do with our protocol, and I think that I teach my medics and Jordan does to his, is that we don't want you to just be like technicians and monkeys following a protocol in the field. We want you to assess the patient, medically think about what's going on and what is going to be the step to take care of them. And if the next step in the protocol doesn't make sense, we don't want you to do that. Correct. If you think, oh, I want to do this, it's off protocol, call us. If you think another protocol applies, then apply that protocol. Or if you want our feedback on it and you have time, call us. We'll listen and we'll either agree or disagree. And if maybe even afterwards we go to review it and we might be wrong. It's okay to be wrong, but we still want to be safe in taking care of what the patient needs at the time.
And I think out of that phone call, too, you can actually plan another step ahead. So back to Dr. Singer's point, I don't agree with this. Maybe I want a different dose, or I believe we should dose maybe down, for lack of a better word. And, you know, our patient only needs 200 milligrams of ketamine. And if you agree, okay, I'm going to give that, and let's say in 5 minutes that doesn't work, am I okay to give another 200? You know, have that conversation ahead of time, I think helps. Then you're only making one phone call, because after you try it until we find out whether or not that medication is going to become effective or not, plan ahead, you know, when you're talking to medical control. I think so. I always like to advise paramedics, if you're calling medical control and you agree to plan A, okay, if that doesn't work, what is my plan B, or what is my second dose of that medication? Have that conversation first, maybe before it becomes more hectic, and then you're not able to call, and then, you know.
So we're talking about having any plan you have, you should always be planning to fail, right? So if plan A doesn't work, what's my fallback plan?
Yep.
So I just got done teaching about cricothyroid training and airways and stuff. When I'm talking about airway management, you're going to have 4 different ways to fail. And what is your failure tree to get down to ultimately it's going to be chronic thyroid? In this instance, maybe I'm going to start with that olanzapines and it doesn't work. What's my next fail step going to be? Because option one didn't work, right? Or if ketamine didn't work and I think there's other things going on, maybe other things are going on and we need to take a different step at it. And maybe sometimes if we're talking about certain patients and overdoses, which I know is one of your favorite, benzodiazepines are going to be way better a choice for a lot of our overdose patients and our agitated patients than necessarily ketamine.
Yeah.
All right, I have a patient, absolute wildcat, flipping cars over when we get on scene. Law enforcement restrains them. I give them 250 of ketamine by protocol. The patient is no longer a wildcat, but the patient's yelling, screaming, spitting, being obnoxious, but is on our cot, and we're in the process of getting this patient appropriately restrained. Does this patient warrant more ketamine, or does this patient need another pathway?
I am personally a fan of kind of picking one drug and sticking with it, just because the pharmacokinetics is easier to kind of figure out because you're not mixing with 2 separate things. So in this case, if you think this person needs additional sedation because they are still fighting enough that it's going to cause issues, because we worry about continuous agitation, because if they're fighting restraints, whether they're hard restraints or soft restraints, that can lead to buildup of potassium, buildup of CO2, buildup of lactates, and all these other metabolic derangements that can be very problematic and even kill patients very rapidly. And so if we think they need further sedation, I would give them an additional dose of ketamine, knowing that when ketamine is dosed fully, people are a GCS of 3. They're literally unresponsive but breathing. That is the intent. So just be aware that if that happens, that's what you expect. But that's also why we have them on Entitle and all the monitors, because we're going to catch anything before it happens and we're going to be ready for it. But if you think that, if you're like, I'm looking at this patient, if I give them any more ketamine, it's going to be problematic, then call med control for a consult in that situation, just because these are very critically ill patients. It's very easy to overshoot and have an issue. I mean, there's a patient the other day that was very, very agitated that I took care of, and I ketamine them, and they ended up vomiting, and I intubated them. That was just something that was going to happen. These patients are critically ill, and guess what? We tend to intubate critically ill patients, but whether in the field or in the ER, it just happens. Our job is just to do everything we can to decrease the odds of that, but also make sure that we're treating the person in front of us.
I would say I agree with you. But if I think that there is a psychiatric component that I think is going to benefit from an antipsychotic medication,
that's fair.
I like the combination, especially if they're agitated, right? They're not aggressive. They're moving around and they're spitting at you. We can deal with the spitting with masks and stuff like that. I like that giving Haldol in that case is beneficial.
Yep.
So that way, by the time as that drug starts to work, you start transporting them, you're not snowing them. We don't have to worry about respiratory compromise, because that's the big concern, right? And I'm getting now the antipsychotic effects, which are probably going to calm the patient down more if this is a psychotic issue. If we don't think that this is, or we think it's drugs or it's some other thing going on, then more sedation is appropriate. And I agree that I would stick with one pony until you've maximized that medication. And then if you have to add something else, it's a call to med control.
Caleb, this actually brings up some stuff that I've talked about in class or in recent history, specifically with some of these hot button things like the use of ketamine pre-hospitally, is you have to know your medical director, what your medical director's views on these things are. This isn't something that you should just be, freewheeling, right? Yeah. Engage your medical director and have this discussion so you know what he or she expects of you in these cases, right? It's best to head this stuff off and have this understood, have a mutual understanding before you get on the call, rather than trying to sort it out and get QA'd after the fact, when you could have just known what the expectation was going in.
I mean, these drugs, especially ketamine, are being watched very closely, not just locally, but on the national stage. And the reason is there have been some really bad outcomes related to ketamine. A lot of that has to do with crews not monitoring the patient well enough. And that's why we say use all the monitors, because if you are assuming that the person you're giving ketamine to is critically ill and needs everything possible to monitor them, you are giving them their best chance. And if something bad happens, that's not because you didn't do something, that's just because it was going to happen regardless. These are critically ill patients, and critically ill patients sometimes have bad outcomes. Our job is to do everything we can to minimize that as much as possible. And I agree that certain medical directors may feel differently. Because it's so political and monitored so closely, if we do have a bad outcome related to our ketamine, it's going to be looked at and combed through very closely, and you could potentially end up on the front page of the news. And you never want to end up on the front page of the news. That means something bad happened. You want to end up on page 8. That means you saved someone's life. So the key is to make sure that you know what your medical director wants, at least how they feel about this stuff, and that if you and that you just cross every T and dot every I when it comes to using these drugs. And then, in my opinion, you can't go wrong in that situation. You've done everything you can in that situation.
All right, I got one last little bit here. Does anybody in the audience have anything for either of the docs? All right, one last thing is how do we apply this in cases of like autism or MRDD patients? Is there any, do we need to change any of our approach? And furthermore, if they are already on a lot of these medications to begin with, how do we refocus our strategy with that knowledge as we get it on scene?
Do you want to take this one first?
No, you're doing
Okay.
So you're the guest.
Yeah. So this is tough, and the key is this is why we, at least in our protocol, don't specify that you need to know the exact reason for why they're agitated. If that patient, whether it's because of alcohol, trauma, some other substance use, or because of underlying MRDD and autism, which often some of these patients can be quite agitated because they're unable to communicate very well. And if you think about the last time you tried to communicate and couldn't, it made you angry. And what if you couldn't communicate with anyone? Then you get really angry. And so that's what happens with these patients. If they're agitated, they need some form of sedative. And you should treat them as you would any other agitated patient. We'll get them under control from an agitation standpoint, which is dangerous for that patient. And then we'll figure out if some other medical issue is going on. And maybe it just turns out that it was just due to their underlying MRDD or autism, and if that's the case, the medication we give them will wear off, they will no longer be agitated, and we'll be able to get them the care that they ultimately need. So if you have to sedate them, you have to sedate them. It just is what's necessary for their safety and your safety.
Same.
He was like, ditto, check. So.
Obviously, olanzapine's not going to work there because they can't communicate with you. I think if they're moderately agitated and you think a benzodiazepine would work, that's a good choice. Again, this is probably not a psychotic issue. I don't need to add on my Haldol. But if, again, they're biting, fighting, swinging, and they're 300 pounds, what else are you going to do? You're going to go for ketamine. And I think Dr. Spinner says it well. Like, if you say, I wish I had a stun gun right now or a taser to stop the patient right now, do what they need, that's when I reach ketamine. That's my ketamine, right?
That's fair.
All right. Ray, you got any other?
No, we actually, we have a facility in our area that has a lot of MRDD patients, and they have their own challenges. And a lot of times when our squad responds there, the caregiver that sees that patient every day is our biggest advocate.
Of course.
They know that patient well, they know their triggers. So a lot of times we're able to utilize a well-known history and someone that spends a lot of time with them to try to de-escalate the situation and just naturally calm the patient down. But if you're out in the public or you're in someone's home or you're in that public setting, it's a lot harder because you don't have any of that. So as Dr. Singer was talking, that was the only thing that I could think of is how we're very spoiled in that situation to have those caregivers know all of the medical history and try to de-escalate the situation. But we have had to go to medication occasionally too, just to make it safe for the patient, to make it safe for us. But they can be very challenging patients to protect.
Absolutely.
Because ultimately, the key is we're giving them the sedative for them, right? If they're agitated, that's dangerous for them. If somebody's agitated, they may run off into traffic and get hit by a car. So we need to control their agitation for their safety as well as ours.
All right. Well, we're right up against time here. Anybody else in the audience have anything they want to throw in before we wrap this up? Dr. Hills? Yeah,
Yeah,
no,
thanks for having us.
we appreciate you hosting us, and we'd like anybody out there in virtual land that would be willing to host us. Again, jump on prehospitalparadigm.com. All the show notes for this episode and all the other episodes with all the episodes, audio, video, product. That's all cataloged there. And again, shout out to FirstNet and Cradlepoint for being giving us the hardware and the tech to get all this out in the world. Subscribe on YouTube, and we'll see you in a month from Kent. Thanks, everybody.